the behalf of Agri Oncology, first of all, I would like to thank Dr. M.B. Agrawal, who has allowed us to be a part of such a wonderful webinar. And I would like to welcome Dr. Cindy Neonert as a guest speaker, Dr. Amit Khurana sir, and all the discussants and the participants who are attending this webinar. Adley Oncology is on the mission of advance healthcare by innovation, quality, and the collaboration. It is one of the widest range of anti-cancer drug manufacturer, which is having 3 manufacturing plants and a strong R&D formulations. It is not only present in India, but also expanding its wings to more than 46 countries. We are one of the first to bring affordable cancer medicines in domestic market like acalabrutinib, carfilzomib, nilotinib, and eltrombopag. I am glad to say that we have recently launched oral methotrexate solution, that is Adexate OS, first time in India, which is bioequivalent to tablets in fed and fasting conditions. Our mission is in hematology is the patient's first is our guiding principles, where we always want to provide patient compliance, patient support, patient education, and cost-effective medicines to all the patients. With this, I would like to say thank you to all of you and hand over the session to Dr. Amit Khurana, sir.
Thank you, Prashant. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Cindy Neonert from New York, USA, and she's going to lecture us on ITP therapies, updates and considerations. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Adley Oncology, and very well managed by Perfect Square. I thank Mr. Ashutosh Shukla and the team from Adley, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Cindy Neonert from New York, USA. All our discussants who are themselves very eminent pediatric as well as adult clinical hematologists, and you participants for sparing a Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 15th of March 2026 from 11:30 am Indian Standard Time, we have Dr. Arundhati S. Athale from Mumbai speaking to us on parenting your own child, a ray of hope for cancer survivors. Let me introduce our discussions for the day, and we have galaxy of them here in alphabetical order. I will pause for a while for you to look on all our discussions for the day who are very eminent hematologists, hemato-oncologists, as well as pediatric hematologists all across the country. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. We have with us no other than Dr. Cindy Neonert from New York, USA. Let me introduce Dr. Cindy Neonert to all of you. Dr. Cindy Neonert is Section Head, Pediatric Hematology at Columbia University Medical Center at New York, USA. She did her fellowship from University of Texas, Southwestern Medical Center, and she's an expert in benign hematological disorders. Her areas of research and specialization include immune thrombocytopenia, hemostasis, thrombosis, and sickle cell disease. She is involved with the Intercontinental Cooperative ITP Study Group, which is an international study group advancing knowledge regarding the natural history of ITP in children and adults. She is also the author of the American Society of Hematology 2019 Guidelines of ITP. She was past chair of the Pediatric ITP Consortium of North America, that is ICON, which is a group of 40 pediatric centers conducting studies on the biology of ITP as well as the conduct of patient-related and interventional trials. She now serves as the co-chair for the international subcommittee. Today she is with us and she's going to lecture us on ITP therapies, updates and considerations. Well, thank you so much. I stop over here. Over to you, Dr. Cindy Neonert.
Hello, everyone, and good evening, or I guess from other parts of the world. Good morning, good afternoon. I'm going to go ahead and share my screen now. And let me just get this mode. So it's really always a pleasure to come and speak to this group, and I mostly look forward to the question time at the end. So hopefully we'll have lots of good time for some good discussions because this is going to be an overview of sort of where the landscape of ITP is going. And I think we don't have clear answers yet. So the discussion part will be just as exciting as all the data that's coming out. So I just want to provide an overview on an update on emerging data for the TPORAs, particularly in children with ITP, describe mechanisms of action of the novel therapies and data for those therapies, and then the impact of those on current clinical trial research design and patient care. And I'm going to try to highlight some of the data that came out from the recent American Society of Hematology meeting, as well as some recent publications just in the beginning of this year. So ITP is a really exciting field and time right now. Things are expanding at rapid rates for us in terms of new therapies coming out. And you can see here, all of them are targeting either different components of the immune system that haven't been targeted before, and or adding to the number of agents that we have to stimulate the bone marrow to make platelets. And I will focus on the ones that either have open clinical trials or had some new or emerging data. But I think this just gives you the overview of how much work is currently ongoing in this field and the number of potential new agents that will be coming out. So this slide really just summarizes where we are with these different agents. So the first on this slide is efgartigimod. This is a neonatal FC receptor antagonist and one that we've talked about in the past. It basically kind of blocks the recycling of those IgGs back into circulation. That's fundamentally what the neonatal FC receptor is responsible for, is that recycling of the IgG. So by blocking that, we're blocking that recycling. There's not really new data that's come out in this. They had an IV study that showed positive results, and then they had a sub-Q study that showed negative results. So they are still now in the process of the advanced next study, which is ongoing with no real new data to present on efgartigimod. But I think it is important to note that the company is still working towards trying to find out why they had a discrepancy in the two initial studies. We will spend some time today talking about rilzabrutinib. This is now approved in the US for the management of ITP. And I will present the LUNA-3 trial that is no longer, the adult portion has concluded. The pediatric remains ongoing. And then there's a LUNA-4 study that also is still open and ongoing. But there was good results that have been now published and discussed about the LUNA-3. Ianalumab is a BAFF receptor antagonist. It has now 3 different trials. VHIT-1 is for first-line use alongside steroids, and that is undergoing enrollment at the moment with no published results yet, but is data collection and waiting report. VHIT-2, however, was used as second line alongside L-thrombopag. This has been completed and recently presented, and I will show you that. And then VHIT-3 has some preliminary results that we'll also present. The other BAFF has an ongoing basket trial. So basket trials are trials in which more than one disease is being explored. So ITP is being explored alongside another, a large number of autoimmune conditions. That trial is ongoing. There's no real recent data to present there. And then the CD38 antibodies, the big one of which there was a lot of data at the ASH meeting was daratumumab. And then Takeda is also still working on mezagitamab and their IV study, which is ongoing. So now to get into a little bit of the devil in the details, but I think it's just exciting even looking at the overview of the things that are going to come out of this. I mean, we have never seen so many trials, just looking at the number of trials listed on this slide, whether they're completed, whether they're positive, whether they're negative. this is a landscape change for this condition. These are therapies that are under investigation for children of those. So there's avatrombopag as a TPORA. This is an oral tablet. It has now been approved, and I'll show you some of the data from that. Rilzabrutinib, we talked about. The pediatric study is still ongoing. It's only going down to age 15. There is an open trial in daratumumab for kids 6 to 18. I'm not going to talk too much about obinutuzumab, but this is another anti-CD20 antibody similar to rituximab, but with a little bit more penetration potentially into the spleen. And there is a pediatric trial open for that as well. So let's look at the TPORA data for children. I don't think that there's been a huge shift in adults other than to discuss really adding them to upfront therapy, which is going to come about with the most recent update to the ASH guidelines, which we're hoping will be published in April. So I'm happy to always give an update on that as well at another time once that gets published. But for children, the biggest thing was the avatrombopag data that finally got completed and published. So this was looking at avatrombopag versus placebo in children, and the primary efficacy was percentage of weeks with a platelet count greater than 50,000 during the 12 weeks without rescue. And in the avatrombopag group, this approached 50%, placebo much lower. When they looked at the percentage of weeks between 50 and 150, that rate was slightly lower at 30%. And I think that this is because in this trial, they had really tight holding criteria. So if children went over 200, they were holding. So I think that created a lot of platelet variability that hopefully we won't see in actual clinical practice. And then we have here rescue therapy, you can see, was clearly reduced with the use of avatrombopag, and bleeding symptoms were likewise reduced. So with this, at least in the US, we now have an FDA approval for avatrombopag. How it fits with what we already have in L-thrombopag and romoplastin, I think, is yet to be seen. We do know that L-thrombopag can be challenging for children with the dietary restrictions, the daily PO needs. Whereas avatrombopag does not have those dietary restrictions. In fact, it's recommended to take it with food. And it also does not have the hepatotoxicity seen with L-thrombopag. So maybe more favorable just in delivery profile. It's also possible with avatrombopag that you can back down from daily dosing, and some patients only even require once a week dosing based on titration. So I think there may be some benefit to yet a third TPO entering into the landscape. We also presented, and previously some of this data was presented on the PINES trial. And this was looking at in children, this was a study done by our consortium group. Could we use L-thrombopag in the newly diagnosed phase of ITP, so within those first 3 months, and get a more sustained and durable response during that window? The primary objective was to determine the proportion of patients with platelet response and to see if that was significantly different between the two arms. And then that was based on a primary outcome of a binary definition of a platelet count, 3 of the 4 greater than 50 during the last 6 to 12 weeks of therapy. And this also required that there was no rescue therapy given. So this is the enrollment here. So we looked at children newly diagnosed requiring treatment. So this was not trying to now expand treatment to all children with ITP, but if they needed treatment, they could be either upfront or a treatment failure. So we had a portion that had never seen treatment and then a portion that were truly a treatment failure after getting IVIG corticosteroids. They were randomized to either L-thrombopag and or standard therapy, which could be at the investigator's choice, but you could not use therapies that the patient had failed in the past. And then here you can see our primary outcome of the 6 to 12 weeks and the long-term follow-up. I think it's important to always look at the population that actually enrolled in the study when we try to translate things into clinical practice. So if we look here, of the kids that were truly that newly diagnosed up front, you're meeting them for the first time in the emergency room or in your clinic, no previous therapy, and within 10 days of diagnosis, that represented about 40%, 30 to 40% of patients. Then we get into the prior therapies. Some patients had failed observation, but were greater than 10 days with that observation. Other patients had IVIG. You can see here steroids. It's interesting to me that steroid use and IVIG use is slightly balanced in this study. But again, this is the population that entered into this. So what did we see? The study was closed to additional recruitment because it showed benefit of L-thrombopag in these children. So you can see here responders in the L-thrombopag group were 63% versus 35% in the standard of care arm. If you look at our totally enrolled, this was a total enrolled, you can see here again, greater number of responders to L-thrombopag than standard therapy. We also saw a difference, a reduction in the need for rescue therapy. Bleeding scores seem to be similar at all the time points. We did have a composite endpoint, which was platelet count greater than 30 and doubling and no bleeding. And this did occur earlier in the standard treatment group versus the L-thrombopag group. And a higher proportion maintained this in the L-thrombopag group, though, at 12 months. So perhaps we get a slightly still greater, more rapid response with corticosteroids and IVIG. So in a patient who really needs an intervention quickly, this may not be the best agent of choice. Overall health-related quality of life improved in both arms, and we didn't see any new safety signals with using L-thrombopag in this setting. So the conclusions were that in pediatric patients with newly diagnosed ITP requiring treatment, this resulted in a significant clinically relevant higher rate of durable response in the absence of rescue treatment during that first phase of ITP management. And the notion was that this could transform our approach and actually maybe mirrors a little of a transition I think we're going to see in the adult world, where I think there's going to be some suggestion of introducing agents like TPORAs or rituximab alongside steroids earlier on. I think we have to be very careful, though, when we try to crosstalk between what we do to newly diagnosed patients in adults and what we do in newly diagnosed patients in children, as our goals are slightly different. I think our goals with that first initial visit with a pediatric patient with ITP, our goal is really to stabilize that patient, to assess their bleeding, to see if we need an intervention while we wait for the disease itself to resolve. In adults, the goal of that earlier upfront therapy is not only stabilization, but really to prevent the high rates of chronicity that occur in adults. So the risk benefit is very different in these two populations, just fundamentally on what we're trying to do. And the number needed to treat to prevent is also much different in the two populations. But I think there is this mirroring in children and adults to not keep waiting and reapplying steroids or reapplying these other kind of what we might call emergency therapies or rescue therapies repeatedly over and over, but to move on to something that might give us a more stable platelet count. At ASH this year, Pines did present the long-term follow-up data showing really no difference overall at 6 or 12 months in children. To me, this isn't very surprising given that only a few patients with pediatric ITP would even enter into that definition or have continued ongoing ITP at 6 and 12 months. Based on this, however, the ICON Consortium has proposed a new treatment algorithm. So what you don't see on this slide is the whole workup that leads us to a diagnosis of ITP. But once we have confirmed our diagnosis of ITP, and we're over here at ITP that is in isolation. And we assess the bleeding. So again, the fundamentals haven't changed. We still are not trying to advocate now, oh, we have these great new drugs and every patient should get treatment or every child should get treatment. But still based on bleeding, if we have grade 3 bleeding that is of concern or some upcoming procedure, the recommendation is now to proceed directly to a TPORA. That if you can't get a TPORA in 24 hours, then you can give prednisone. But even with prednisone, the minute you get TPORA approval, you should start that TPORA. Over here on this is just you have access to a TPORA, you should go straight to this pathway. You can consider an initial course of prednisone, particularly recognizing that there may be those patients that you want that faster rise in platelet count. So perhaps there is still a population in which you would consider steroids, reserving IVIG based on the previous 2019 guidelines for really those patients that need a really robust rapid response for significant bleeding. So to me, this pathway is really changing pediatric management of ITP. Again, I think it's going to mirror what's going to come out in the upcoming ASH guidelines about introduction of these agents earlier in adults as well. I think there's still a little bit of what we have to learn as we implement this pathway of cost, which I'm very aware of knowing that historically 60% of patients that get a course of corticosteroids will never need retreatment, and recognizing that in the Pines trial, only 40% of patients, or 35 to 40% of patients were this exact group, and we don't have a subgroup analysis. There was not enough data there to really do a subgroup analysis to know sort of what happened. And we also don't know what happened to the patients that got treated and did not fail a first-line therapy and did not need to enter onto this trial. But I think this is a quality project. It is worth doing. I think it's looking at the more practical side of implementing this and understanding why physicians would or would not apply a clinical trial in practice, because we're going to gather data on did the patient get a TPORA or not? If not, why? And I think that will show us access barriers, cost barriers, physician reluctance. So I still think that implementing this is of high value and high need. Is this a desirable model everywhere? I don't know that it is. And again, I think this would be a lovely discussion point because I think this is really moving the needle for pediatric ITP in a direction that we've not done before, and should be done very thoughtfully. So now on to sort of the new exciting landscape, not just kind of how we apply previous therapies. Rilzabrutinib is a BTK inhibitor. It's something that a lot of people are already aware of because of its use for leukemias. The previous BTKs, the problem was that they caused platelet inhibition, which obviously would not be desirable in a ITP population. However, we've now seen with rilzabrutinib that we don't have that same platelet dysfunction, making it a safe drug to bring into this space. And it really does have a wide net for immunomodulation that would make it a good agent to try. So LUNA-3 data has come out. This was looking at rilzabrutinib 400 milligrams twice a day versus placebo. And the main endpoint was at 12 weeks. Patients had to come in with a transient response to first-line therapy, but then having failed that, and this was only looked at in persistent and chronic. So they have not moved into the newly diagnosed space yet. But they did have a lot of patients, 200 patients. Most of them had chronic ITP. Most of them were previously treated, and over half had more than 5 therapies. And there were 28% who had undergone a splenectomy. This shows all the results. So a durable response was achieved in 23%. Overall response was 65%, which is based on just a platelet count. What I do like about rilzabrutinib is it has a rapid median time to first response compared to some of the other oral immune modulators that we may use. And it did show some improvement in fatigue and health-related quality of life. So it may be one of the few drugs that has shown improvement in fatigue, making it perhaps a good choice for those patients. And here you can see platelet counts over time between the two groups, showing a positive effect of rilzabrutinib in this previously heavily treated population. Despite a low durable response of only 23%. Again, I think we always have to look at the population and recognize that inherently this is a population that has failed multiple therapies. So now the anti-CD38 antibodies, based on literature review, we know that daratumumab is a good drug, and daratumumab and mezagitamab have both been investigated. I'll present some of the data on daratumumab that's come out. Mezagitamab, as I said, Takeda has studies ongoing. There is a daratumumab pediatric trial open that has ongoing data collection. So this is the DART study. This is all recently presented at ASH and in publications. This was a multi-center open label phase 2 trial of 21 patients looking mostly at safety and efficacy. And this was more for kind of an earlier use, but patients still had to have failed corticosteroids and at least one other TPORA or rituximab. And then there were guidelines about when to use this if somebody had gotten rituximab. There were 2 different dosing cohorts based on the number of injections given, either 8 or 10, and it was a flat rate of 1,800 milligrams weekly. In the first cohort, they got it weekly for 8 weeks. In the second, it was weekly for 8 weeks, and then they went to every 2 at week 10 and at week 12. And this really was truly a safety and a basic response study where they looked at 2 consecutive platelet counts for this during this time. Because it was primarily safety, the treatment of adverse events mostly were transient, and the greatest number were transient infections. There were only 2 patients that had grade 3 adverse events. There were 10 patients that met the primary efficacy endpoint, so that's almost half. And there was a sustained response in 38% of patients. And relapse rates did not differ between the 2 cohorts. So regardless of the dose, patients had similar rates of response and relapse. Again, a sustained response was really only 2 consecutive platelet counts, but this was at week 24. And remember, the last dose was given at week 12. So 40% were able to hold on to that between week 12 and week 24. Health-related quality of life improved in those patients who responded. And then they also looked at time to treatment failure, which was about 22 months. So patients that had a response were able to hold on to this for some time. And by the end of the study completion, there were almost 30% of patients that had maintained response without additional therapies. They looked specifically at the group that had daratumumab following rituximab therapy. This was 16 of the 21 patients. Of those 16, half met the primary outcome. 6 of those 8 were still responding at week 24. So of those that had prior rituximab exposure, half were responders. Of those responders, the majority were still responding. So of those that responded, the majority was a durable response. And of the 4 that had previously responded to rituximab, 3 of them responded to Dara. So I think that maybe what this tells me is that there's no direct relationship to if you responded to rituximab, you're going to respond to Dara, or if you did not respond to rituximab, you're not going to respond to Dara. But none of the 5 who had a previous splenectomy responded to Dara. So just of note, maybe this is not a good therapy for patients who have undergone splenectomy likely because of its mechanism of action. This just outlines what we talked about in numbers, but pictures are often a bit better. So this is showing study weeks and our responders. This is our daratumumab. And here, same thing. Here's responders, and then our non-responders. So again, up here, this was not a placebo-driven study. So up here, we have our responders. Of those that responded, the platelet count did seem to maintain a nice platelet count, compared down here to those who did not respond, which makes sense that these were our non-responders. This just shows this differently: response, sustained, and basic and sustained, not showing any differences between the two dosing cohorts. I do like this. This was a percentage of patients without a treatment failure, so needing to go back onto therapy. And you can see here, this is that roughly, they said there were about 40% of patients that still had a response at completion of monitoring without treatment failure. So, and this is just showing the reverse of that, which is the number of patients that didn't relapse. There was a presentation at ASH and also at now published in the American Journal of Hematology of daratumumab in pediatrics. Small study of 11 patients. They gave 16 milligrams weekly for 2 to 8 cycles. And basically they determined the number of cycles based on a drop in platelet count. So a platelet count less than 30,000, 4 weeks apart, you got another dose of daratumumab. This shows the average number of doses. The majority of patients, you can see here, needed 4 doses. So, that seems to kind of mirror a little bit about what they looked at previously. Here's a graph of what each of the patients look like. About 55% had a complete response at the time of follow-up. Median time to onset was 2 days, which to me is also pretty good for these kids that have a lot of bleeding, or patients who have a lot of bleeding that are failing therapies, and we need to do something quickly. There was no treatment that was discontinued due to an adverse event. One child did develop persistent hypogammaglobulinemia. And again, this has always been our concern with using these therapies in children. Even with rituximab, is, some patients not repopulating their immunoglobulins. But you can see here, I think the thing that's nice about this is just visually, you can see that the majority of patients stayed in a CR or PR even after their last dose of DARA was given. So I think that is encouraging for daratumumab as a therapy. I'm not going to talk too much about obinutuzumab, but there is an open study for pediatric patients. An open study that also is including patients 12 to 18. So we'll see how this works and how it compares to rituximab. I did want to highlight an abstract at ASH, the PROLONG study. This is a multi-center phase 2 study looking at maintenance rituximab. So something that I think a lot of us have thought about is, we do look at the DARA study. They kind of based it on a relapse. And if you relapsed, you got another dose. Is it reasonable to think about using rituximab this way? So again, not a novel therapy, but an existing therapy that we're trying to figure out exactly the best way to use it. This was an adult study, 130 patients, done by the group in Norway. And they gave rituximab with or without 2 cycles of dexamethasone. And the maintenance phase then was looking at either rituximab 500 milligrams or placebo on week 0 and 24 after they got randomized from coming off of the initial treatment. And what they were looking at was a sustained response during maintenance therapy. And they defined that as looking at how long somebody went to having a loss of response. So 2 consecutive measurements of platelet counts, less than 50,000, my apologies, at week 24. So at week 24, about 40% of patients achieved a response to rituximab versus 60% in Ritux and Dex. So I think what they concluded was that Ritux plus Dex seems to be a better model. Again, this mirrors what is about to occur with some of the data coming out on upfront use. I don't think people are advocating for upfront rituximab without some dexamethasone. These were not upfront patients. These were patients with persistent and chronic ITP. They did not see a difference in the use of rescue therapy, and there were some serious adverse events that were reported, but none that were enough to discontinue study. 46% of the patients who responded to induction therapy entered into the maintenance phase, and they've not seen any SAEs during this maintenance phase, and they're still doing analysis of the maintenance phase to really know if maintenance therapy improves outcomes. I do think the good news is that they have not seen any SAEs, and I think that's the important message because I think that's our concern with reapplying rituximab. And I think it's interesting that they're using this low dose rituximab model. So really moving towards more of a true maintenance. And what does that look like? I think here too, a little bit of this is, should we be basing it on biology? Should we be basing it on just set time points? If a patient repopulates their B cells, is that the time to give it? Or should we be waiting until they have a loss of response? What really are going to be the patterns? So I think that the large number of patients in this study is really going to give us some rich data on how to do this. I think they're showing that it's safe to do this. I think now we have to think about the how in practicality. And how does repeated courses of rituximab fit with what we're going to see in the daratumumab study that's coming out and that story? And is it better to switch to something else and target a different compartment versus continuing to give rituximab? I think what they're going to look for in this is just showing that a few doses of maintenance can keep somebody really in a long-term remission. But again, I think as we have these other agents coming out, it's really, we're going to have to see, where this now fits in terms of how we practice. So ianalumab is got a planned pediatric trial, but has some really exciting data that's out now that was published in the New England Journal in 2025. This was the VHIT-2 study. This was a randomized phase 3, and this was looking at ianalumab with L-thrombopag in patients who had failed to respond to a first line of corticosteroids. As I said, there is VHIT-1, which is looking at ianalumab plus steroids in the more upfront phase of treatment. So we're still kind of waiting that data. In this study, they gave ianalumab as either 9 or 3 milligrams monthly for 4 months, and then L-thrombopag daily until a taper at week 24. And they were looking again for treatment failure. And I think this is really a nice model. Everybody's applying kind of this time to treatment failure, which gets at what you want to know, which is how long can patients really go without falling back into the zone where they need treatment as the primary outcome. And it accounts for more than just a platelet count. So the probability of being free from treatment failure at 12 months was the same in the two groups and higher in both groups than with placebo. Also, a stable response at 6 months was higher, and this did favor the 9 milligram group. And the frequency of adverse events was similar among all the groups, so no increased signal over placebo with the ianalumab and also ianalumab in addition to L-thrombopag. VHIT-3 has also come out. This was an ASH abstract presented this past December. This was a smaller trial, but just looking at ianalumab as a single agent for patients who had failed corticosteroids or a TPORA. Any additional previous therapy was allowed. So this was a much more just, can we use ianalumab, not in combination, not upfront, but just what does it look like if we used it similar to how we use rituximab? In this study, they did use the favored 9 milligram per kilogram dose every 4 weeks for 25 weeks. And this was at week 25. If patients had a response, they were continued to be monitored until, again, they had a treatment failure. And their primary outcome was a platelet count greater than 50,000. But then they also are looking at this treatment failure. So this is a large previously treated population. Median number is 6, greater than 4 therapies in the majority. 93% were able to receive all 4 doses without any trouble, and 44% of the patients had that confirmed response over 50,000. 56% of responders were able to have a stable platelet count ongoing at 6 months, and there were no new safety signals. I think this tells us that about 40% of patients did not maintain that stable platelet count at 6 months. How many doses can we give with what frequency? This is going to need to be kind of, I think, the open question for ianalumab and the data coming out. I'm really also excited for the VHIT-1 because I think that this is also the space where we need data, which is what happens when we do these things up front, particularly in adults with such high rates of chronicity. So now just to look at what is going to be the impact of these therapies, I think that we're seeing high therapeutic success in patients who had failed multiple lines of therapy before. So that's encouraging. I think some of these provide really prompt and good sustained platelet counts. We have good safety profiles overall, making these look favorable. I do like the idea we're starting to get IV therapies, sub-Q therapies, things that we can give less frequently. I think this really may improve our patient satisfaction and patient adherence, and not really having to think about living with ITP all the time. Removing or decreasing or eliminated steroids, I think what you hear from patients is 2 goals. 1, they don't like steroids. 2, they want to see if there's anything they can do to live in what we would call that sustained response off treatment. They just want to be not reminded daily of having ITP. It doesn't mean that they have to have a normal platelet count, but if they could buy themselves time not having to take medication every day with a platelet count that lets them do what they want, that would be considered a success to them, to that individual patient. As we do any of this, as this field gets flooded, as there's companies racing to get their data and design their trials, and I think we have to come back to a few fundamental guiding principles. That is that we really need data on sustained response off treatment. That's easy to define, I think, for oral medications, right? You get on an oral medication, you stop it, and either you have a response or you don't. And this is the story of the sustained response off treatment that's coming out with the TPORAs. I think that for the other drugs, for these monoclonal antibodies, how do we really know when a patient doesn't have drug in their system anymore? But again, I think that may not matter to patients, right? Again, a sustained response off treatment just means they're not currently still undergoing treatment. I don't think that the patient is aware of what the biology of that medicine is still doing in their system. What matters to them is hearing the words off treatment. I'm no longer getting or receiving an active treatment. It doesn't matter to them if they're not getting it because they stopped an oral pill or they're not getting it because it has such a long-lasting effect. We absolutely need to continue to get patient-related outcomes in our trials. We always have to come back to the guiding principle that for both adults and children, the treatment should never be worse than the disease itself. That is a fundamental hard stop. Cost is going to be a huge part of this, as is shared decision-making. Even for the PINES trial, using L-thrombopag upfront for children, we're undergoing a cost analysis right now to really look at what does this look like, the number needed to treat, and the high cost associated with that, compared to a brief short course of corticosteroids. And this notion of shared decision-making and how do we support patients and physicians in putting all these new things together and having a dialogue about them, particularly when we don't have what we would love to see, which is the precision medicine of oncology. I think when it comes to trial design, we need to remember that we can use umbrella studies where it's one disease with multiple therapies being investigated versus basket studies where a small number of ITP patients are represented in a drug that's just being tested for autoimmunity in general and is in studies with MS and lupus and all these other things. We need strong advocacy. We need strong advocacy that if there is an effective treatment, it needs to be available to patients globally. It needs to be affordable to patients. There's a strong component of advocacy, pushing it through regulatory agencies. I think we continue to still need registries. We need registries like the France group has that are amazing sources of clinical and biorepository data that can really help us identify perhaps the refractory patients and what's best for them and what they may need. So this is kind of my conclusion slide, but I felt that more guiding principles was a better place to end because that's really what these are. Whether we're talking about ITP or anything else, these are really the guiding principles in my mind as I try to think about how to translate this very complicated landscape into patient care and clinical practice. So I will pause there, give you all time to digest, think of questions, and I'm really interested in the dialogue piece of this because, like I said, I think we may be left with more questions than we're going to have answers here shortly as these things come about.
Thank you, Dr. Cindy Nunit. Wonderful lecture, as always. And now I request all our discussants to please put the hand raise signs so we can start the question session with Dr. Cindy Nunit. So before the questions keep on rolling, let me ask some few questions to you. In your definition relapsed ITP, you used, for example, every lines of therapy, you used a TPO receptor agonist, which is prevalent in India. L-thermopeg romiprostin is of no use because once the patient relapses on L-thermopeg romiprostin, you are left with nowhere else. You also used rituximab. Patients already splenectomized, and patient still has got refractory ITP. So what would be your next line of therapy after this? Your patient is used up with steroids, used up with IVIG, rituximab gone, MMF gone, romiprostin gone, L-thermopeg gone. Patient already splenectomized. Such bad patient, again, patient is platelet count less than 10,000. How do you approach such patients? And what would be the next line of treatment for such patients? You're muted, Dr. Cindy.
We use a fair amount of sirolimus in my practice, which I do think even at low doses, not, targeting a goal of 8 to 12 for a level, but even without that 8 to 12, I've seen some patients respond even though their sirolimus level is like 2 or 3. I think that daratumumab, there's pediatric data, the dosing is there. We've given daratumumab to some patients as well. I think the craziest approach I've heard is CAR T coming out for really refractory ITP. There was actually cases reported at ASH on CAR T in adult patients with ITP. But my go-to is something along the lines of a sirolimus. There's also some 6-NP data, although if a patient hasn't responded to MMF, and then there's dapsone, there's azathioprine, there are some other things that could be tried. There is data growing on dapsone, and I think it's reasonable. Azathioprine we use in, pregnant adults. But I think this really refractory group is where we've got to be the advocates to get these new therapies to these patients. And particularly as a pediatrician, right? I mean, these drugs come out for adults all the time. I now have some teenagers that I'm starting on rilzabrutinib. in the absence of pediatric data, because that's what they need. They're the exact patients that you're describing.
Thank you. And you said about when the patient is splenectomized, DARA is of no use because that has not worked anymore after splenectomy.
Right. DARA did not work for those five patients that were splenectomized, but 0 had a response. So, we don't do a lot of splenectomy anymore. So for us in our population, and I think even in the adults, I think this is a little bit of why they're not. I think again, this is more support for why a patient, should not be undergoing splenectomy early in the course of their ITP unless it's for actually a life-threatening bleed. And I think the guidelines are going to continue to support that even in adults.
Thank you. And what is the maximum dose of L-thrombopag you will use in ITP?
So you can go up to 75. I don't go any further than 75 with L-thrombopag. And then for Ramaplastin, I go up to 10 and I cap there. I see there was a chat comment about dose adjustment for Ramaplastin. My practice is to start high and go up quickly. So I start at 5, I go up by 2. Now with people, some of the icon centers, based on this new proposal to use TPORAs instead of steroids up front, people are giving 10 mics per kilo of Ramaplastin in the ED and letting kids go home. So again, this is where I think doing this kind of quality project, we can learn really what's going to be done in clinical practice. But I don't follow the 1 mic per kilo slow adjustment. I don't find that it is necessary. I think that was very cautionary dosing because of, the safety in a clinical trial. But I think in clinical practice, we're going to see that we can do it much differently. And then the other question was about differentiating. And what I was going to say about the patient that you brought up, that's absolutely a patient too that you should be looking for. Maybe this isn't ITP, right? Making sure we really rule everything out in these refractory patients.
True. Regarding if your patient is already given rituximab to the patient and the patient has done very well for about 2 to 3 years, after how again the patient relapses, can you go for reconsider rituximab? And if yes, then what should be the dose of rituximab? And and should we go with the same dose again and again or should we retry the patient with rituximab? That is the first question. Yeah.
So this is great timing because of this prolonged trial that's going to come out. Really a good study by Wally Gima and his group. So I think they're going to answer some of that question. They used 500 milligrams as a retreatment dose, as a flat dose. For pediatrics that may not fit as well. I've actually started to use some of the lower dose rituximab. So instead of the 375, it's the 100 milligrams per meter squared. And I would feel comfortable perhaps redosing with, 100 as opposed to another 375. But again, I don't think we have great maintenance data. But I think if somebody had a good response to rituximab, it's worth trying again. Although I have to say, I have a patient that had autoimmune hemolytic anemia. Beautiful response to rituximab. Now, a year and a half later, has ITP. And I went ahead and tried rituximab again, and it did nothing. And I was very sad. But I think we'll see. We'll see with this maintenance phase and what we learn from the prolonged study. The ASH guidelines, at least for adults, are going to have a commentary on the fact that it is reasonable to consider repeated courses of rituximab in adults. So I think it would be very fair to say the same of children.
Thank you. And is it true that if the patient has got the secondary ITP secondary to APLA, are they going to respond very well to daratumumab? Is it so?
For which secondary to which drug?
APLA. If the APLA
I don't know that
antiphospholipid antibody positive.
Yes. So, antiphospholipid antibody positivity is a different beast. And I think what's hard to know about antiphospholipid antibody syndrome is, does that patient truly have ITP, or is it thrombocytopenia that we see just with antiphospholipid antibody syndrome? I also am curious, the French group has some data on hydroxychloroquine use in patients that have sort of this ANA positivity, antiphospholipid antibody type picture. I think that is the group that people are nervous to use the TPORAs in. But I don't know, the group that we know responds to rituximab well is the young females. That seems to be, although now I think there's a group that's sort of saying their data isn't matching that per se, but I think that is the group that we all know. I don't know with antiphospholipid antibodies. Certainly patients that have any underlying kind of lupus-like picture, I think rituximab is a good drug.
And if the patient feels rituximab is DARA way to go?
I think Dara I just think there's something inherent about those lingering plasma cells, right? Like I just think that might be why patients are failing rituximab. Although what's interesting is when they looked at the biology of patients who failed, it seemed to be more the Treg compartment that didn't switch over, that responders show a change in the Tregs, but it might be driven because if you have persistent plasma cells, that memory is all still there. So yeah, I think DARA is a reasonable drug to try. And I think we're getting data on DARA. The data is out there on DARA. The DART study is out there now. I think it can give us some confidence in using it.
Thank you. Dr. Deep Gala, your question.
Thank you, ma'am, for taking us through this host of options which we have for ITP. My question is regarding combination therapy upfront using steroid with MMF versus only single agent corticosteroids. So how do we fare, ma'am?
So this is the data that came out of the FLIGHT study. And when we looked at this for the guidelines, the FLIGHT trial did not quite meet criteria for becoming a suggested upfront approach. The preferred upfront approach was, and these, I don't know if they're still available for public comment, but we're aiming for publication in April of the updated guidelines. The preferred first line upfront was TPORA or rituximab and steroids. MMF did not quite hit good enough targets, but I think some of it is what's most available, what is easiest for a patient to get. And I don't think there's any plans to continue the FLIGHT trial. So despite a really nice randomized trial, the MMF combination with steroids up front has not quite been superior to either TPORAs or rituximab.
Okay. Ma'am, I have just one more question. I just want to know, how do you counsel patients who have platelet count of 50,000, 70,000, but they have extremes of symptoms of fatigue, cramps? So how do you go about this? How do you counsel them? They are the most difficult to counsel.
The fatigue of ITP is really a space that I think we need to delve into. I think that, rilzabrutinib helps fatigue. You can't justify giving rilzabrutinib to somebody that has platelet counts of 50 to 70,000. Although if it improves their fatigue, a patient might tell you it's worth it, right? The risk. I counsel them the way I counsel anybody with fatigue, which is a little bit of sort of not a push through it, but when you feel the most fatigue, that's when you have to really try to get up and even do a small walk, even do something, engage in something to not give in to the fatigue. I really do make sure that there's not anything underlying that's organic iron deficiency, anything else going on with mental health aspect of things. We haven't really tried to address it by giving antidepressants or anything like that. It mostly comes down to some counseling. And there is good literature to support this from patients. Liver cirrhosis patients, it's another area where there's a lot of fatigue. And there's a lot of data on just ways to reframe the brain around fatigue by trying to push through it. Easy to say here, really feels unfair when you say it to a patient. But unfortunately, it is the best that I think people recommend for the fatigue associated with inflammation. And again, we don't exactly know what's driving the fatigue.
Thank you. Any other question, Dr. Deep?
Thank you, ma'am. No, sir. That's it. Thank you, sir.
From the same note, do we need to treat ITP who is presenting as fatigue? Like 1,000 patients coming as fatigue, do we need to treat them or no need to treat such patients?
You know, now that rilzabrutinib is out there, maybe there's no data that any agent given for ITP changes the fatigue yet. We know they improve platelet counts. We don't have great fatigue data. This is why I think one of the stressed points is that we really need to capture fatigue in clinical trials. In our ICON study, fatigue did not seem to correlate with response to therapy. So even patients that have a response in their platelet count may still continue to have fatigue. I think it depends on an individual risk assessment, right? Where is the patient's platelet count? How significant is the fatigue and how much is it impacting their daily activities to say we should try something, right? At some point, I think people are saying maybe that's a patient to try rilzabrutinib in because it does have fatigue data. But again, if that's not an option, you have to dig into something else. So again, I think it has to be individualized based on really listening to what that patient is telling you, and thinking, is there anything else that you could do for this patient? Because there's no guarantee that increasing the platelet count is going to help the fatigue.
Thank you. There's a question from Dr. Emon Tent. How do you differentiate ITP relapse versus drug-induced thrombocytopenia?
Yeah, I mean, I think at this, there have been a few reports, at least with romiplastin, of antibodies, drug antibodies, and the company will test for that. Outside of that, I think it's really just stopping the drug, and then seeing, what happens to that platelet count in the absence of drugs. I think the other setting in which we're going to see a lot of drug-induced ITP is now in our leukemia patients getting things like blinatumomab and things like that. Like, I think we just don't know what all these immune modulators are going to do to giving us drug-induced ITP, even long after the patients have seen the drugs. So.
Thank you. Another question she has is, how do you manage ITP in pregnancy, especially 30 years female, pregnant, fit, got ICH, intracranial hemorrhage, moderate rise in D dimer, LDH elevated 2 to 3 times, presence of fragmented red cells in the peripheral smear, occasional polychromasia, platelet count of 30,000, proteinuria 3+, normal LFT, normal creatinine, normal blood pressure. What is your opinion for such patients and how do you manage this?
So I'm going to have a full disclosure here that I treat pediatric patients and don't have a lot of pregnancy management experience, except for a few teens that I've co-managed with adults. One thing I would think about with this patient is this ITP or is this something else, particularly with the LDH rise and the 2 to 3 fragmented red cells. And some proteinuria. I would really just make sure that this truly is a patient that has ITP. This feels like something that is maybe not in the field of ITP. That being said, ITP in pregnancy, we can safely do splenectomy if needed. We can do azathioprine if needed, and we can use IVIG. The other thing that we've seen that I think is really going to come out is safety of TPORAs in pregnancy, particularly after that first trimester. Later in the pregnancy, I think there's some data coming out from the French group. Terry Gersheimer's done a lot of work to really show that these are potentially safe agents for the 2nd and 3rd trimester of pregnancy.
Thank you. Other questions from Dr. Manoj. 3 years female, ITP, post IVIG, no response. Initial got a CR, but after 2 months she got a relapse. Our current platelet count is 12,000. No bleeding manifestations. Secondary workup is negative. How do you approach such case? and patient is not affording for again second dose of IVIG.
So this, and how far is this child into their ITP, if I can ask?
So
Are they still in the first 3 months, or are they
first 3 months, because the
first 3
patient
months? Yeah.
between the 2 months. Yeah.
So, great question. I think, and this is my space. Thank you for coming out of the pregnant women. I love the 3-year-olds. So, this is a case where I think this is where the Pines trial, this is the exact patient that, to me, the Pines trial makes sense. If you feel you need to treat this patient, I mean, that's always the first question, right? With a pediatric patient, the first question should always be, does this child need treatment? You may find that the answer is actually no. Despite a platelet count of 12,000, they're not bleeding, they've never historically bled, their quality of life is not impaired, and they're okay, right? Those are I also always look at, like, what's their social structure look like? How easily could they get to the hospital if needed? But I think this is exactly the population that the Pines trial speaks to, not giving repeated courses of things like IVIG or steroids or any of that, and just going on to a trial of a TPORA if you feel like they need treatment. And I do feel like the Pines trial really did justify that. I'm still struggling a little bit with, like, trying it before you even give steroids to a patient. But I think this child is exactly the child that the message was, take them off the up and down roller coaster of all these other drugs and just get them on a TPORA.
Thank you. The trial of avatrombopag is over, right?
Ava's over, and our Pines trial with L-thrombopag is over. Yeah.
Avatrombopag is over and it's been FDA approved now.
Ava is FDA approved for us in the US. Yeah. We are using it quite a bit. I do like it, and it does give us another agent to try to switch to within the drugs. I find that a lot of children on avatrombopag don't need it daily.
And what is the cutoff for avatrombopag? Age group?
Down to a year. It starts at a year, similar to the other two. And it comes as like a sprinkle. It's like a sprinkle that you sprinkle on whatever they want.
Any incidence of having thrombosis with L-thrombopag in children?
We looked at this in our kind of real world experience with the TPOs, and I want to say that we had a small number of patients with thrombocytosis, not resulting in any adverse events or outcomes. So it can happen with any of the TPORAs. You can get thrombocytosis. It seems to be rapidly reversible just by adjusting the dose or holding, and does not seem to be linked to the cases of thrombosis.
Thank you. Again, the patient is pregnant lady. Again, next question is that Dr. Christopher, you want to answer? It's okay. Otherwise, I just read out the question to you. Dr. Christopher has raised the question. Pregnant lady, newly diagnosed ITP, responded to high-dose steroids, but relapsed upon steroid taper. Didn't respond to IVIG. What should be your preferred second line?
I mean, azathioprine is the one that is safe, can be used in pregnancy and would be the first thing I would go to. I would also revisit if there's any benefit of azathioprine of retrying IVIG to see if you get some synergistic benefit there that you didn't have with IVIG as monotherapy to support you. But I think then this is where, if you're out of that, if you're in your more second, third trimester, you could consider a TPORA after a good risk benefit assessment. I have also given low dose rituximab to somebody who is pregnant. The risk there is more to the infant, right? That the infant then gets born with neutropenia. But if you're really in, a less than ideal situation, people have done very low dose rituximab during pregnancy, but you have to then anticipate neutropenia in the infant, which is not great. I do counsel my young women that if I know that they're difficult to manage, I try to initiate early conversations about family planning, introducing the fact that rituximab is a great option if we know we can plan and give it far enough in advance of the pregnancy. And do use low dose rituximab in advance of the pregnancy, recognizing it may still have some effect on neutropenia, but hopefully we're mitigating that.
Thank you.
Yeah. So I think it's just an important piece of counseling young women with ITP who are of childbearing age to really be open about discussions of family planning, even if they're doing well on a TPORA. If they're planning to get pregnant, the sooner you start that planning, the better.
Perfect. Another question from Dr. Nutan Joshi. ITP patient on TPO-RA develops thrombosis, like cerebral venous sinus thrombosis, wherein the patient requires anticoagulation. So how do you manage such patients? And yeah,
We just had a good debate about this in our ITP group. It seems to be a split group. Some members of the group said, well, if you're going to anticoagulate, you can stay on the TPORA because you're anticoagulating anyway. So stay on the TPORA, maintain your platelet count, and give anticoagulation. Other people, it was probably a 50-50 split. Other people said, I would absolutely stop the TPORA, find some other way to maintain the platelet count and give anticoagulation and not put that patient back on a TPORA. So I think there's a definite split in opinion. I was in the camp, I switched my patient to, I had this exact scenario. It's very terrifying. I switched her, I gave her rituximab. Thank goodness she responded and we anticoagulated her.
so
But others have maintained the TPORA saying, well, now we're anticoagulating. So the risk of thrombosis on a TPORA is gone.
yeah, thank you. So if the patient has improved, platelet counts have improved, patient has developed thrombosis, but by the time the platelet counts are already improved, do you wish to continue TPO-RA and anticoagulate again, continue with anticoagulation at the same time? Or you would like to change the entire treatment because already the patient has improved the platelet counts. So
Yeah,
you go on continuing with the TPO because that TPO it actually helps the patient to improve the platelet counts. And
yeah.
but the patient develops thrombosis. The platelet counts are normal, but now the patient develops thrombosis. So would you like to continue with TPO-RA or you like to change the therapy, give some another therapy, discontinue entire treatment of ITP?
So I'm in the change therapy camp. But I will tell you again, there are people that would continue the TPORA and just do anticoagulation and then keep the patient on but my thought there is then what's my question when I was with this very same patient was like, then what is my endpoint for anticoagulation, right? If I keep the patient on a TPORA, am I ever going to feel comfortable that then they can come off anticoagulation while receiving a TPORA, right? Or is this a patient that now I'm committing not only to an ongoing TPO, but also to lifelong prophylaxis with anticoagulation? So my thought is get them off the TPORA, do the anticoagulation as long as I need to treat the thrombosis, and then hopefully have them on a completely other agent and not on ongoing anticoagulation.
Thank you. Another question is from Dr. S.K. Sharma. Do you check pediatric patients for H. pylori? If they are found positive, do you treat them in the absence of symptoms?
So in the US, we don't have a lot of H. pylori, so it is not, we follow the guidelines, which is if the patient does not have symptoms, we do not test. But if they do test positive, then we do treat. I think in areas and regions where there's high rates of H. pylori, routine screening makes sense. It just does not for us in our population unless there are symptoms.
Thank you. And again, the same question is from Dr. M. Velu. The patient develops L-thrombotic on develops thrombosis on L-thrombotic. Do we need to continue the drug until apply is excluded? And the answer is you switch over, right?
Yes. And absolutely those patients should be tested for antiphospholipid antibody. And I think it's debatable. I think some people would argue you should test for antiphospholipid antibodies before giving someone exposure to, there's a little debate about this in the adult world, but I think in general, that is the one. There's a lot of debate about if TPORAs cause thrombosis. I've heard David Cooter and Wally got like they've debated this. If is it really the drug? But certainly the antiphospholipid antibody patients, I think people are more cautious about using a TPORA in that setting.
Thank you. In pediatric patients, which TPORA actually you prefer, L-thrombopeg or romiplostin?
I kind of leave it up to families. I find my families, I might be a little different. I'm able to get a lot of home use of romiplastin, so I find that my family is actually kind of like that. Particularly the teenagers, they really like doing once a week injections and then not thinking about it and not keeping up with a daily pill. I also have a population of patients that have a lot of dietary restrictions for religious reasons. And so for them, it's just much easier to do something that doesn't have additional dietary restrictions. So I think it really comes down to patient preference. To some families, doing an injection is not ideal. So I think it just really comes down to patient preference. Um, I think they all work equally as well.
Thank
And
you.
a little bit of it is cost and insurance in the US. I mean, sometimes we don't have a choice. We do what the insurance company tells us to do.
Thank you. And last question, regarding the use of L-thrombopeg in children, what should be the dosage based on the body weight and based on the age of the patient?
So I follow the FDA label indication, which I don't know off the top of my head, but it gives very good milligram per kilogram dosing information in that. And it is weight-based up until a certain weight, and then at a certain weight, you resume kind of the adult dosing, which is reasonable. I'm happy to just see if I can quickly pull that up since we have a little bit of time. Just to give you exact details, because I always have to, I do look it up. Bum, bum, bum. I will get back to you. If there's other questions, we can keep going with those.
And the last question, which has just come up, is in patient of chronic or persistent ITP, the patient responds very well to sirolimus. How long do you will continue sirolimus?
I've had kids on really long courses of sirolimus. I keep going. I don't stop it. If it's working, I just keep using it.
So you will reduce the dose to the lowest possible dose of sirolimus?
Yeah, and again, I have found that some patients aren't even in my range of 8 to 12 with the level, but they just respond to like this whiff of sirolimus in the background, very small amount. So yeah, it's just it's interesting to me.
Okay. So thank you so much, ma'am. Wonderful discussion we had.
So 1 to 5 years of age is the 25
Hmm.
powder, and then once they're 6, it goes to the 50.
50. So more than 6 is 50 and under 5.
Yeah, I'm confirming, but that's but there is a milligram per kilogram dose.
Right. So less than 5 and more than 6. Right.
Mhm.
Fine. Great. So I finished all the questions from the chat box. And anybody has any other question over here? Well, so I think there are no more raising signs. Thank you so much, ma'am, for a wonderful,
Lovely.
wonderful discussion. And I now hand over.
Absolutely wonderful.
Mr. Prashant Agarwal for the final vote of thanks.
Thank you, Doctor. Thanks a lot, and thank you very much for giving us opportunity to be part of this wonderful webinar. And good night to all of you. Shabba khair. And thank you once again from the on the behalf of the Adley Oncology. Over to you, sir.
Thanks a lot. Have a nice time.
Thank you, everyone.